What I just want to mention is that what changes did it bring? Of course, I do not want to be too much optimistic. It's a strategy. It can make some differences, but it will not change the situation fundamentally. The benefit I see from this strategy is first that it offers a platform for better mutual information of the relevant ministries and of the various stakeholders from the civil society, from the private sector, from the health system actors. So it's a platform for discussing and for better coordinating our position, Switzerland's position. The second benefit, of course, is that thanks to this policy and thanks to this better cooperation, Switzerland speaks with one voice in international fora, and I think it's very important. It's very important for a country that we do say the same story. If we speak at the World Health Organization, at the World Trade Organization, at the World Intellectual Property Organization, whatever the ministry is leading. Of course, all those organizations are covered by different ministries, and it's important that we develop a consolidated language, a consolidated position. Of course, it takes much more time. It's sometimes difficult to reach consensus, for instance, in Switzerland on the issue of access to medicine. We have a strong industry, medical and pharmaceutical industry, and it was not self-evident at the beginning to reconcile the view of our development cooperation colleague with the view of the office in charge of defending intellectual property rights. But I think we have now a very balanced position on this issue of access for all to indispensable medicine, a position which recognizes and stresses the urgent need of access for all to this medicine, and at the same time values the contribution made by innovation and research to the development of new medicament. I want to finish with that, and I will give the floor to our main speaker this afternoon, President José Ramos Horta. I don't have to introduce you to his extensive biography. He has been the president of East Timor, the prime minister also of East Timor. He's now the UN Special Representative for Guinea-Bissau and the head of the UN mission, the head of the integrated peace-building mission in Guinea-Bissau. President, the floor is yours.
Thank you. Thank you. Main speaker doesn't mean necessarily the most inspiring, and I'm afraid I will read to you what I had written as abstract for the conference. And because I'm not, it's not my field, health, I thought I would write something, but I just didn't have the time. So the only thing I have written is the abstract. I read it to you and I elaborate further. And I read, extreme poverty, severe malnutrition, hunger, lack of access to clean water, basic health care, electricity, pollution, environmental degradation caused by human activity, by wars, by weapons exports. These are all part of our global health or lack of it. Look at the conflict in Syria or Libya. What exacerbated the conflict in those two countries? Decades of massive weapons exports to Libya and Syria. And when the system, the state breaks down because of what happened there, popular revolution, the whole health system breaks down, the state disappeared, almost literally, at least in the case of Libya, not to mention the ramifications, security ramifications of the weapons exports to Libya. For instance, the problem in West Africa, particularly in Mali, is a ramification of the weapons that excess weapons that were there in Libya before. And I don't, of course, the recipient regime that ordered those weapons, Gaddafi of Libya, Assad of Syria, of course, they had their own perceptions of their security, the perceptions of threats to them. But the exporting countries were also very happy to satisfy those perceptions by selling them weapons. It was good business for them. And now everybody harvesting the consequences of those policies. That's why I put here, weapons exports. Leaders in the rich north and those in the emerging south might consider to answer this. Question to the rich north, why it was always so difficult, and it's even more today, to find money for ODA, and yet they easily find hundreds of billions of dollars to rescue failed banks, insurance, housing companies, and to pay tens of millions of dollars to incompetent and greedy CEOs. Who wants to work for the UN? We are poorly paid. I already told the Security Council in New York, when I finish my current mission, I go and work in the Wall Street, because you immediately pay a few $1 million, you bankrupt a company, you are not fired, you don't get arrested, you leave with a bonus, a package. That's the best possible job. I would advise anyone interested in a job to look for such jobs in Wall Street or in banks in UK, because these are the two most notorious ones. And be a peacemaker to prevent wars. Ending conflicts is not highly rewarded, particularly when the major powers, all they have done in the last 20 years in the discussion about reform of the United Nations, not really to expand the Security Council, to be more representative of what the world is today, with India, with Brazil, with South Africa, with Indonesia, Nigeria. No, it's cost-cutting. Reform for United States and few others is reduce cost. Do more with less. So there is demoralization, throughout the UN. What it was 20 years ago and what is today. UN agencies included that perform great services in many developing countries when the state cannot function. It is UNICEF, WHO, World Food Programme, FAO, UNDP that perform those functions. So I continue. For us in the South, so we are from the developing country, and I can speak freely because I come from South-South. You cannot be more South than Timor-Leste. So, real South. And we also have to answer questions. Can we end corruption, waste, mismanagement? Can we buy less deadly weapons from the rich north? Weapons that actually were never used to fight anyone, to fight the Americans or to fight the Chinese or the Russians, no, to fight among the neighbors in the poor South or within the poor South, interstate wars in the South, among the fraternal South countries. Can we spend more on our youth, give them better education and better health care? Obviously, we haven't done that. Maybe some exceptions in the developing countries. Can we spend more on high-quality, world-class institutions of research and hospitals, and less on soccer stadiums and other extravagant international events? Frankly, I don't know why, and pardon here if there is here any diplomat from Portugal is here, my humble apologies. A country of 10 million a few years ago, for just, not even for the World Cup, for the Euro Cup, Portugal spent $4 billion on 10 soccer stadiums. Some of them empty. Brazil, unlikely that any Brazilian diplomat is here, so let me refer to that. And Brazil spending $14 billion for the World Cup. One of them is in Manaus, that usually only 600 people go and attend the soccer. In Manaus, but the soccer stadium in Manaus is to host 40,000 people, when the average is 600 people. And I don't know what is our obsession with soccer stadiums. You know, why wouldn't we build world-class research centers? One of the best things built in Portugal in the last 20, 30 years is a foundation called Champalimau Foundation by a Portuguese billionaire who passed away. He didn't leave the money to his family, maybe some to his family, but most of it went to this world-class research center. More than 100 scientists work there. Instead of those soccer stadiums they built a few years ago, they could have done half a dozen of those and put in Portugal on the map, Brazil included. And of course, we also the developing countries. Can we spend more, use the money on more tangible and more beneficial priorities like education, health, food security, environment, sustainable development? And I conclude this abstract by saying an enlightened and humane foreign policy is one that through ODA, but not only ODA, fair trade. Fair trade means a level playing field where the US and France don't subsidize their cows to fatten them up and make them cheap, so that, and then make it very, very difficult for the developing South to provide, to export to Europe. So if we cannot just look at ODA as such, it has to be an integrated approach. And we've been talking about this for 20 years with no agreement in sight. Socially conscious and ethical public and private sector investments. There's a movement, and there are some progress in that regard. Aims at a global health achievable through targeted strategic investment towards eliminate extreme poverty, illiteracy, malnutrition, malaria, HIV, AIDS, sustainable development, clean environment, drastic reduction in weapon manufacture, import, export, disarmament. If we don't address all of this, any approach to health in foreign policy will continue to be band-aid. And a few years ago, I was in New York. I was still president of my country, attending the General Assembly. It was immediately after the breakout of the world economic financial crisis that's still ongoing. I heard speeches after speeches. Whenever I spoke at the UN, I speak for 3-5 minutes because mostly no one listened to you anyway. And if you're Barack Obama, they listen. If you're Francois Hollande, they listen to you. If you're Merkel, yes, they listen. If you are, so generally they don't listen to each other. And so I don't like wasting paper because it means one more tree goes. So I mostly ad-lib. And I say, well, if you're terribly interested, go to my website and you'll find my speech. And sitting there one lazy Friday afternoon, because Friday afternoon at the UN General Assembly, hardly anyone is there. So, but throughout those days of the speeches I heard, every OECD leader country said the following: foreign aid, ODA, will not suffer, will not be penalized because of the financial economic crisis. I heard, I was sitting there, and I comment to someone sitting next to me, I don't believe them. They will cut. And now everyone has cut foreign aid. Every single Western country. Not that foreign aid in the past has been very effective. It was not. The ratio of how much a country pledge, let's say for Afghanistan, let's say $100 million for Afghanistan, and how much actually is spent in Afghanistan is about 10%. In my own country, Timor-Leste, the international community was extremely generous. But in reality, when we did the calculations, but real serious calculations by many, many people, only 30% of the monies were spent in East Timor. So I coined a phrase. Foreign aid doesn't mean they spend the money on East Timor. They spend the money on East Timor, but not in East Timor. On East Timor meaning to do a simple project, infrastructure, many different committees, commissions, studies after studies do it. In the end, only maybe 50%, 30%, 10% of the money is spent in the country. And that applies to across the board. With exceptions. Of course, you're dealing with different countries. Some fit in what I described, others not. Others make every effort to really spend the money in the country, in infrastructure, in poverty reduction, in healthcare sector, in education, et cetera, et cetera. So there has to be a real rethinking. And I'm not saying anything new. The so-called Accra Declaration, the so-called Paris Declaration, Busan Declaration, all have referred to a so-called New Deal, whereby there is a two-way street in terms of accountability. Recipient countries accountable for what they receive. Donor countries accountable also to the developing countries, in the sense, transparency. What you're really pledging, what you're delivering, where, how, let's all verify it. That would change probably the whole picture. And last but not least, in foreign policy, how health has been also sometimes victim of foreign policy. The most blatant instances a few years ago, because of sanctions on Myanmar, the sanctions have been lifted since, but a few years ago, because of sanctions, UN aid was forced to pull out of Myanmar because of US sanctions on Myanmar, congressional pressure. So, and at the time I criticized and I said, I'm sorry, but I was opposed always to sanctions on Myanmar. Suu Kyi knows my views on that, because I disagree. Sanctions on fragile countries that are already victims of their own regime. You impose overall sanctions, the suffering people are the poor ones. The ones, the military and the others, well, they go off to Singapore for treatment. They go to Thailand. They don't suffer from the sanctions on the health sector. In Guinea-Bissau, I don't know how many of you know, able to locate where Guinea-Bissau is. Ban Ki-moon, certainly he doesn't like me, so he sent me to Guinea-Bissau. The other day I found out there is a UN office in Bahamas. I'm going to tell Ban Ki-moon, sorry, after Guinea-Bissau, I'm going to Bahamas. to the office in Bahamas. But Guinea-Bissau, West Africa, surrounded by Senegal, Conakry, border with Gambia, blah, blah, all of the countries in the region. 40 years independent, the state literally doesn't exist. The army completely dysfunctional. Politics dysfunctional. The country bankrupted economically, although potentially enormously rich. No lacking of water, of rainfall, fertile land, great fisheries, the best in the entire west coast of Africa because of the waters, the mangroves, and so on. And yet, because of the most recent coup in 2012, European Union and everybody else, including African Union, imposed sanctions on Guinea-Bissau. And the health sector, education sector also were victimized. Fortunately, recently I managed to persuade my brothers and sisters from the African Union to please resume assistance on the health sector. And they allow the African Development Bank to return within a matter of weeks following my appeal to Guinea-Bissau to resume support for infrastructure, medical equipment in the health sector. The health sector and education should be exempted from sanctions when regimes are at fault, people are at military coups or whatever situation, because it does affect the poorest of the poor, because the richest, they are never affected by that. So these are my comments. I thank you.
Thank you very much. Professor Kazachkine, I wanted to see if you could address in your current role, you're at the center of many of these political disputes as the UN Special Envoy for HIV/AIDS in Eastern Europe and Central Asia. Tell us a little bit about how you negotiate the ground between politics and global health, especially when you're working not only with fragile states but with maybe totalitarian regimes as well.
Yes, thank you. Good afternoon, everyone, and thank you, President, for these comments. You know, before I was in this role of Special Envoy, I had other experiences in global health diplomacy as an AIDS ambassador for the French government, acting on instructions, then when head of the Global Fund, actually watching the scene somehow. And I've seen many of the sad things that you have been referring to, at the same time as I also have seen what the global international community can achieve when it really comes together. So we should keep a very balanced view, I believe, here on all of these, the outcome of these tensions. Now in this role of envoy, you know, clearly the UN Special Envoys are, I believe, a part of the global health diplomacy constituency or a community. They, as the UN, basically have no decisional power. They have no financial power. They cannot exert pressure with finance. They receive no government instruction, obviously. But they have, as the UN has, legitimacy, as also President Ramos Horta was somehow referring to. Legitimacy of the cause, and I find it interesting that basically every single global public good, as we think of them, has a special envoy or several special envoys. They have the legitimacy of the commitments that the nations took at the UN through General Assembly resolutions, through the Millennium Development Goal targets. And they have the neutrality and I would say the transparency of the UN. No hidden agenda. It's here working on the cause, about the cause, and here health and the health of people and nothing else. Now, to answer your question, I'll just focus on what I'm actually doing and learning to do in a situation which is extremely tense, as you know. AIDS is a very sensitive issue in Eastern Europe and Central Asia, a politically sensitive issue, a societally sensitive issue. And it's a region where I guess people know that the AIDS epidemic, and the same is true for tuberculosis, is actually continuing to grow at a very alarming rate. Today, between 2 and 3 male adults aged 30 to 35 out of 100 are infected with HIV in the Russian Federation. And as you know, the epidemic has historically largely been driven by people who inject drugs. It's now shifting to a generalized heterosexually transmitted epidemic. And the whole epidemic is evolving in a climate of stigma, discrimination, marginalization of the most vulnerable groups, criminalization, aggressive law enforcement, underfunding of the AIDS response at a time when the international donors are actually leaving these countries. They're leaving these countries because the dogma of ODA, and I fully agree with you, we have to move out of the original dogmas of ODA. We are in a post-ODA era now, because the original dogma of ODA is north to south, poor, rich to poor. And the world has changed. But the driving force there is still we need to focus our health primarily on the poorest. And I would like the assistance to be where it's needed. And it's not because many of these countries have become middle income or even upper middle income countries that they are actually providing the resources to the people in need. So the crisis is fairly acute, and this, of course, in a climate of political denial and no political involvement. So very briefly, what is it that I and my fellow envoys in other regions of the world are trying to do, but here I'm illustrating this particular region, 4 things. One, in a few countries, and the example here is Ukraine or Kazakhstan, we're actually working to try and identify with all the stakeholders, that is the government, but the civil society, the communities, what are the issues of political nature that, if addressed, would change the course of the epidemic. And then me, as envoy, bring those issues to the highest possible level. And to give you an example, in Ukraine, there are 2 things that are coming out from this dialogue. One is the need to reform drug policies, and the other is the need to find a contractual form of associating the civil society and the government that in most countries in the post-Soviet sphere are, there's just no dialogue between the civil society and the government. The second way of working is more regional, and here it's an attempt at the level of the CIS, the Community of Independent States, to have them move towards a declaration on financial sustainability of the AIDS response, or have these countries commit to financial sustainability. The third is working on a crisis mode. 10 days ago, I was in Bucharest, where an epidemic outbreak of really extremely concerning magnitude started a year and a half ago, right after the Global Fund funding stopped. And the NGOs therefore closed, because there's no support for NGOs from government. NGOs disappeared, one after the other, and at the same time, these were NGOs that were distributing sterile needles and syringes to people using drugs. And at the same time, the people who use drugs switched from heroin to what's called legal highs and some of the synthetic drugs, where you inject actually maybe up to 5 times more times a day than when you use heroin. So the need in needles increased. The two factors combined, the proportion of people using drugs among new infections of HIV in Bucharest raised from 5 to 6% to 53% just in 6 months. And the latest assessment of how HIV is prevalent among drug users in Bucharest is 52%, 1 out of 2. And finally, when you deal with the most, I would say, difficult countries, and let's say the Russian Federation, my answer is, at this time, the only thing we can do is try and start a dialogue and maintain a dialogue. And that's, not necessarily something of which you can think it will have an impact immediately, but that's also how diplomacy works. A patient discussion, keeping the dialogue, raising the interest. Not necessarily cost-effective, but absolutely necessary.
Thank you very much. If I could just ask a quick follow-up, why did the global funding stop in Romania?
Because Romania entered the European Union, and that's a criteria of non-eligibility.
Thank you. All right. So that's a nice transition. Mr. Schulten, if you could tell us about Germany's new global health approach and why you've come up with it and how it addresses some of these issues maybe that we've heard so far.
Okay, thank you very much. I will be very brief because our minister will be speaker in the opening ceremony and will provide you some more in-depth information. So I will be very brief and give you some appetizers for today's evening. So on the 10th of July, the German cabinet adopted the strategy paper Shaping Global Health, Taking Joint Action and Embracing Responsibility. If you look at this date, you see that summer break followed, and then election campaigns in Germany. So today it's the first time that this concept is presented to a larger audience. So what is the background of the concept? In drafting this paper, the federal government is preparing to meet new challenges in global health policy. Germany's contributions to solving global health problems shall take on a new quality. The coordination of the many different forms of engagement by a broad range of German actors will be improved in order to make Germany's contribution more effective. And in order to sharpen Germany's profile, it is necessary to focus on areas in which Germany is comparatively strong and can make a sustainable contribution to the improvement of health. So this is why the German federal government has decided to concentrate on 5 priorities. First, providing effective protection against cross-border health threats. Second, strengthening health systems throughout the world. That means facilitating development. Increasing intersectoral cooperation. That is interaction with other policy areas. Promoting health research and the healthcare industry. This is providing important impulses for global health. And strengthening the global health architecture. This prioritization does not mean that all other activities are sundown activities. We are still committed to some older policies, and we will be open to new challenges in this way. This is just to contour the German strategy. So, and the concept is the basis of our global activities are universal values. So, I citate the German Constitution, Article 1, Para 2. Human rights as a basis for any kind of solidarity, peace and justice in the world. Then the UN Declaration of Human Rights from 1948, the design of the global health policy in line with the European Union and its bodies, and what's very important for us, the inclusion of the civil society. And in preparing the concept, we had several meetings with NGOs and other parts of the civil society. It was our explicit wish to include them. So there are some underlying principles for Germany's engagement in global health policy. It is guided by the following principles: protect and improve the health of the population in Germany through global action, embrace global responsibility by providing German experience, expertise and funds, and strengthen international institutions for global health. So, finally, what difference will the concept make? No? Does it have any clout? So, the federal government seeks to act in a more consistent manner in the area of global health. By adopting the strategy paper, we will achieve the greatest possible degree of consistency among the policymakers responsible for questions related to global health. Through close cooperation between the federal ministries, the federal government ensures a coordinated German policy, and especially in relation to the United Nations and the European Union, as well as other international forums relevant to health. Already today, the federal ministries involved regularly coordinate themselves on issues of global health relevance. This instrument will be expanded in order to ensure joint planning and coordination of the German contribution, as well as drafting the concept. This was a joint exercise of several federal ministries, for example, Ministry of Health, then the Foreign Office, the Ministry for Development Cooperation, and others like the Ministry for Research and that for Justice. So, this being said, it's clear that the adoption of the strategy paper is only the first initial step. By adopting the paper, we hope to initiate a broad discussion and new dynamics that will help to bring global health policy on the top of the general public debate. Thank you.
Colonel Nickel, and in the interest of full disclosure, I should say that I know Colonel Nickel. We worked together as I was on the Harvard team on the project that he's going to talk about now from the NATO's Joint Analysis and Lessons Learned Center, looking at how security organizations can support health system strengthening in crisis-affected fragile states. So, Colonel Nickel, let me ask you a question that it's not a rhetorical question, I'm still asking it. Why is NATO interested in health systems? If you could take us through it.
I will not answer the question, but I hope the question will be answered after I spoke. As I have been introduced, I'm Colonel retired now, who worked in NATO's Joint Analysis and Lessons Learned Center in Lisbon, in Portugal, for the last 5 years. And the last 2 years, we did a project which has been mentioned on health system strengthening in crisis-affected fragile states. And this is what I would like to brief you on in the next few minutes. The aim of this study is to illustrate for NATO how security community interventions affect health systems in crisis-affected fragile states. And the focus within this lies on the interface between global actors. Target audience, of course, is NATO decision and policy makers, but also decision makers, policy makers in member states and in other relevant organizations. I would like to make it clear in the beginning, this was not an attempt for NATO to enlarge our mission or to get more tasks in these fields. It is very clear to NATO that its core task is, in very short words, is defense and security. And NATO fully recognizes that in stabilization and reconstruction efforts, including long-term stability and strengthened governance, primary responsibilities lie with other actors. If other actors are not available, NATO can be asked to jump in and fill gaps, but this is an exception to the rule. To address this civil-military interface adequately, we linked up with Harvard University, with the Harvard Medical School, to support us in this project. And through Harvard, of course, we engaged their network into Harvard Humanitarian Initiative. We had engaged ministries of foreign affairs, ministries of development, universities, other relevant centers, and many, many more. We did 4 case studies, or the project is based on 4 case studies, which we did in operations in Haiti, where NATO was not present, but the security community. In Kosovo, the operation in the 90s, and of course the 10-year engagement in Afghanistan, which brought the majority of lessons for NATO in this field, and Libya, which we consider to be a very good example to coordinate military action, military operation with civilian players. Each of these cases is unique, but they all meet 3 criteria. They are all fragile states, and health systems are threatened by a crisis. There is a crisis response directed towards the health system strengthening, and we have a multinational military force presence. I would like to cut this short. The findings we found in all these cases that under different aspects, the military contributed directly, indirectly to the topic of here health system strengthening. Be it the fast relief in Haiti to opening supply chains very quickly, enabling the help for other forces, or be it supporting the polio eradication campaign. We supported this campaign by staying away, by staying out. A good example of how the military can support health system strengthening by a non-standard means, staying away. Finally, some conclusions, and I would like to say that these are preliminary conclusions because the project is in its final phase at the moment. But the cases showed that military engagements have definitely an impact on other domains like health systems, be it active, be it passive, intended or unintended. These actions are closely interlinked with development action and can support an overarching goal or be detrimental to it, depending on how these capabilities are employed. Security community contributions were successful where they were well coordinated. They failed where they were not. They were successful where actors had known their counterparts personally, understood their role and intentions, were working in a sphere of confidence and trust, and where actors realized and followed an overarching goal. In these examples of fragile state situations, all global players are engaged at the same time in the same space. However, everybody has their own role to play, has their own scope, and has their own timeline. And as I said once, it is like everybody is working on the same patient and not talking to each other. And this requires that we have a concerted, a comprehensive approach to this. The most critical factors hampering this goal were the lack of information exchange or the information exchange mechanisms, lack of coordination, missing support to achieving this overarching goal, or the absence of an overarching goal at all. And secondly, international diplomacy, so we think, plays a very decisive role. Nations' diplomats are designing the international community's responses to crisis through UN resolutions, through mandates. So they are in a position to set the frame for a comprehensive international action, and they can be setting the overarching goal to be achieved by the international community based on a 3D or on a holistic approach. So this perhaps answered your question. I thank you for your attention.
Thank you, everybody. So I'd like to pose a question to the whole panel, and whichever of you would like to answer. I'd very much appreciate getting several of your perspectives from the many hats you've worn across these different sectors. We've talked about taking a more comprehensive, integrated approach to global health. But as Ilona pointed out in the beginning, there are a lot of dangers there. There's a lot of tensions that arise when global health could, for instance, become a tool of a so-called soft power tool, whether for foreign policy aims, economic aims, or security aims. So let's talk about that. If you could maybe, because I'm a journalist, I'll ask you to be concrete and maybe just give an example of an area where you think this has kind of been dangerous and how you think we could move beyond that.
A comprehensive integrated approach doesn't mean that a single country, be it Germany or Japan, have to undertake such global integrated approach. There are many partners, and the main partner is the national partner in a given country. They are the primary sovereign entity. They should be in the driver's seat. Usually develop strategic plans in different sectors, including health sector, and then look for partners to support. What I'm saying is that, let's say in a given country, Guinea-Bissau, everything is priority there, and that includes the reorganization of the entire state. I have argued with the Security Council, the European Union, and now it is on the discourse of the Secretary General and everybody, and that is, we cannot continue in situations like Guinea-Bissau and many others to focus and be obsessed with elections. Elections are held, and then the international community, more or less, business as usual, pack or leave. In the case of Guinea-Bissau, is a total failure of the state. So following the elections that we hope will take place in the next 3 months or so, there will be, I call it second phase of international involvement, whereby from A to Z, in every key ministry, there is international support through secondment, collocation, whereby, let's say, IMF or any government will provide support to completely reorganize the Ministry of Finance. Then you have a global aid, a global fund, or World Bank or ADB Africa provide support to the reorganization of the entire Ministry of Health. So there has to be a complete, and some use the expression, refundação do Estado, rebuild the state, refound the state. The state is there, but ceased to exist literally in the course of the last 40 years of mismanagement. So you refound the state, as some call it. I prefer to call it reorganization and modernization of the state. And that's where you have a chance to establish health policies, appropriate ones for post-conflict countries, fragile states like Guinea-Bissau. And it has to be, as I say, integrated, comprehensive approach. In my own country, Timor-Leste, in the past, very different situation because it was not a state entity, colonial entity, then came the referendum, then transition to independence led by the UN. So the UN took the role with support of the international community, including Germany, in building up the country, the institutions from scratch. And then after 2 years, 3 years, After 2 years, the country was declared independent. Not enough, obviously. It was largely formal independence. And since then, we have had to really build up the state. But building up Guinea-Bissau, rebuild the state in a comprehensive manner. If you focus only on the health system without intervening firmly in the Ministry of Finance, in the office of the Prime Minister, in the central bank, forget. After 6 months, you will see the health sector collapsing.
Thank you, Sam. A few comments on this. First, I would very much follow what President Ramos-Horta just said. Integral, comprehensive, and this means at all levels, at the country level, as you just said, but now at the regional level, where more and more things happen in the world is now a sum of regional efforts from an economic and political perspective, it seems to me, more than it is coming in together globally. And third, of course, at the global level. And that means that at each of these levels, we need a governance mechanism that builds this integration and this comprehensiveness. And that's where we're, at least partly failing at this time. Although I believe that, again, collective efforts such as building the Global Fund to fight HCV and malaria are really good examples of what can be achieved. But we're missing a global health governance structure that is clear. We're missing regional global health governance structures. And at the country level, as you just said, the Ministry of Finance, the Ministry of Health often don't talk to each other, and the Ministry of Foreign Affairs is a third interlocutor. To go to your point on the tensions, I mentioned the tensions, for example, between global health and human rights in the region that I'm focusing on now. But there are many unresolved tensions that the lack of global governance sort of allow to express. And one concrete example, if you want, is the paradox between everyone's strong commitment to have affordable drugs for everyone and intellectual property. And this is and the fact that whenever we have one mechanism that allows for progress, let's say the Doha Declaration, then it is bypassed by bilateral agreements such as those that the US or the European Union are imposing on countries. So we're really in the middle of tensions, and François, spoke about a balanced view on that. I really think we should go further than balanced. Health is the primary concern of people. Health is about fundamental equity. So we really need to get the goal of health above a number of other considerations, and that requires huge efforts on global governance.
So this failure to really build country capacity that we're taught, this has kind of been an underlying theme here, that we've been doing medical interventions, but we haven't done nearly as good a job building up countries' own capacities, and there hasn't been proper integration and support for not only ministries of health, but as you said, ministries of finance, and also I'd add in infrastructure ministries. Why is that, though? What's the reason that we've been so narrowly focused and kind of missed the larger picture? Are there political issues there behind it? Structural problems, demands from the donors?
Well, I'll just answer quickly and then I'll shut up. But yes, donors have their priorities, and donors will direct their aid to one or the other of the areas. Then, as also you pointed out, Francois, very rightly so, the people whom a donor country sends to the World Bank, the directors, refer to the ministries of finance in the capital. The people who go to the World Health Assembly refer to the Ministry of Health in the capital. The people who will attend the board of the Global Fund refer to the Ministry of Foreign Affairs. And there are still very few donor countries, now I'm speaking about the donor countries, where all of these efforts come together in an integrated fashion. So that structural problem, plus the fact that each donor sets its own priorities, is certainly one of the factors. The others being, of course, on the side of the countries, where, as President Ramos Horta said, there is also, particularly in fragile states, no integration and no building whatsoever of a comprehensive strategy.
No, maybe on the comment on the issue on this issue, just to stress that it's part of the human being to choose the easy solution, and probably it's much more easier for many people to deal with one specific organization with their own priorities and avoid the need of coordinating with others. And it strikes my attention that even in Switzerland, where we have a strong culture of cooperating together, of trying to build consensus on policy strategies, where this culture is part of our DNA, actually, it's often difficult to coordinate our approach. And as Michel rightly said, the Ministry of Finance will develop its position for the International Monetary Fund. In the World Bank, you may have the intervention, the complementary intervention from the development colleague, but they will not try and care for what is said within the World Health Organization, or within the board of the Global Fund, or within the board of the UNAIDS. So it's easier to let everybody do its work. It's much more difficult to coordinate. But at the end, if you do this coordinating work, you have a strong advantage. First, you have a credibility advantage. Your position takes more into consideration all the relevant factors, and you have a more profound vision of the problem, of the issue. I don't know if that's what I wanted to say.
Thank you. I think we've just got a few minutes left, so let's get some questions from the audience. And so we can get in as many people as possible, please try to give us a concise question. Thanks. Anybody? Oh, there's a mic up, I think, right?
I'd like to once again introduce myself. I'm Dr. Salima Bhatia from the Ministry of Health in India. Now, the reason why I'm speaking is because we faced a similar problem. A few years ago, we had vertical programs for disease control programs, for RCH programs. And what we did is we brought in a National Rural Health Mission, okay, which essentially got a convergence of the programs and focused on system strengthening, under which we set up certain structures. For example, at the national level, we have a mission steering group, which has representation from the Ministry of Women and Child Development, from the Rural Development, from a few other ministries. Yes, we have not been able to actually bring in finance ministries into it, but and similar structures have been established at state and district level. What I am actually looking at is, shouldn't we at a global level be moving towards such kind of structures? Because we at the country faced such a issue, and we brought in this kind of a program. I mean, this kind of I don't know, it's just something to think about. Thank you.
Anybody want to take that on?
Well, there have been a number of interesting suggestions actually also coming out of the debate around health and foreign policy and this group of foreign ministers that I spoke about. There's been a commission working on global health governance, which will present its proposals quite soon. And there are a number of suggestions there how to bring the actors at the global level together in a new way. There's been a suggestion for a coordinated UN panel on global health, which brings key UN actors together. But that is explicitly focused not only, as we have examples now, of global health organizations coming together, but literally looking at, where is the food security element, where is the environment element, where is the financing element. So that's one round of suggestions that's been put forward. Another is much more linked to a broader stakeholder type of approach. So there have been suggestions that, like, there is a food security council which brings in a wide range of stakeholders from different ministries, from the private sector and from civil society, that they are brought together to jointly help coordinate and set global health agendas. And that is very attractive because there is a certain fear if there's another UN coordinating body that might not be quite as lively as one would wish it to be. On the other hand, we have the example of UNAIDS, which has brought the actors in the UN together, plus civil society and other actors. And it has made a significant impact in taking agendas forward, in creating transparency, in developing policies at the country level. And actually the head of UNAIDS, Michel Sidibé, has suggested that the global health governance should consist basically of three big domains. I'm not sure if they're organizations. One is really an organization that truly focuses on the normative issues that we need to resolve for global public goods. And that would be basically the World Health Organization, but supported in the way, I guess, that Kishore Mahbubani sort of outlined earlier today. The second would be a grouping of the many funding organizations, because here's where the major problem lies, that each of them have their separate accountability mechanisms, also different reference groups, and don't pool their funding. And actually it's the pooling of the funding that really supports countries to do what they want to do, rather than to live up to results-based donor ideas that don't take into account the way change is actually affected in a country, particularly institutional change, would be addressed through that. And the third is then to have that kind of UN alliance for global health that would continuously seek to gain accountability and transparency, and do much of the type of advocacy work that has been raised. So those are some of the ideas that are out there in the discussion of how can, at the global level, how can there be more focus and more coordination. There have been many attempts at country level, sort of one UN and one AIDS and, country coordination strategies and whatnot by the donors. But they have not had the impact, really, that one had initially hoped, because also the more results focused in a market type thinking that development agencies are moving into, the less there will also be a will in cooperating, because each agency has to show that it's made a difference on X. And that kind of thinking doesn't allow you to do the kind of structural and long-term building of capacities, of building the state, of building institutions, that is really needed. That has a different accountability mechanism than if you have to report back, how many bed nets have you distributed. And we're still in global health, as important as bed net distribution is, we are still more focused on that side of the agenda than on the kind of deep structural agendas that have been raised here on this panel.
If there's another question, please go to the microphone.
Paras Pokhrel from Nepal. I just want to know when we talk about global health, do we understand the global health same way? And is it defined in consensus? Is it the some of the university going to Africa or Asia to do some research in neglected tropical disease? Is that a global health? Or some sorts of poverty medicine, alleviating some poverty, that is a global health? Or something which is not in the, we just changed the terminology from international health to the Department of Global Health. We do not have a standard defined criteria to say the global health. Among the universities, I suppose 8 which are here. So I think that there is I heard that today morning there is a Berlin Institute of Health. I wish that can define global health in the future, and we will understand the same when we talk about global health. If we understand global health, then we can talk about global health policy. That is just, I think this is, if some plenary diplomat or anybody will say that what we understand for global health, if just change of name or something we have added on it. Thank you.
Yes, I try to answer this question very popular, not very elaborated. Global health has to do with globalizations, because we have much more flights in this decade than in decades before. That means that cross-border healthcare spread very much faster than they did before. Then, globally, some lifestyles and behaviors, patterns of consumption become more similar. And so as well, non-communicable diseases spread globally, not only in the developed countries as well as in the developing ones. And so, and globally means not only international cooperation within UN institutions, it means as well bilateral cooperations in the world, or other fora like G8 or G20 and so on.
I think we have time probably for one more question.
It's working now. Oslo Augusto from Portugal. I would like to ask a very general question. So the donations are quite changing. So this shifting from north-south to a south-south cooperation. But also funding is draining. So are we looking for a new framework of international cooperation for health and donation, or are we simply changing actors here?
That is not quite clear yet. And it's very interesting to actually watch how South-South cooperation is developing. I was at the first ministerial summit of China and Africa just a couple of months ago, and it was maintained that this was a model of South-South cooperation and partnership, but it was not quite clear, and a number of the Africans that we spoke with voiced this, that they said, you know, where is the difference? And it's quite a debate that the BRICS countries, for example, themselves are having. All of them have started to create development agencies, and many of them have a history of sending medical teams, of helping build hospitals, of doing medical diplomacy in a sense, in terms of, you know, also old ideological links when the socialist countries helped each other in that way, and Cuba to this day is a big example of that. A number of the countries of the South, like Brazil, when they say we do South-South cooperation, they say that they will focus on structural cooperation, so that they would help build a medical factory in Mozambique, for example, or help create schools of public health rather than individual health programs. So I believe that is one of the most challenging things right now. Will the model of financing really change, and will the mode of how it is done really change as the new actors come on the scene, or whether it's just, you know, a repetition of some of the things that have been happening because of the geopolitical importance of the alliances and the cooperation. So it's not quite clear yet. There's a lot of ideology also around South-South cooperation, and it's very intransparent at present. At present, actually, North-South cooperation is more transparent and can be also criticized much more easily than South-South cooperation, where the financial flows are not transparent and not clear at this point in time.
If I can just elaborate a bit further on this. First, I would support everything Ilona has just said, but I would like to add that to the debate we have been having today, another dimension that your question points out to is that the whole concept is in a constant dynamic change. So here we're talking about the change of the north to south logic somehow into a south-south, or let's say multipolar sort of logic. We earlier in this debate discussed the fact that health is not anymore just about development. It's also about trade. It's also about foreign policy. It's also about power. It's also about human rights. There are shifts in populations. The poorest people of the world are now not only in the poorest countries. Actually, 70% of the poorest people in the world are now in middle-income countries. And 75% of the HIV patients are now in middle-income countries. And then, of course, and I have also seen the actors change. A few years ago, I saw the diplomats, I saw the experts, and I saw the activists. And now we have seen a number of diplomats become experts in health, a number of experts in health become diplomats, a number of activists become almost professionals in the field. So all of these boundaries are sort of changing, and this dynamic dimension, I think, is one of the issues your question is alluding to.
Can I add to that? In terms of regional cooperation, you know, if you look at 50 years ago, if we talk about South-South cooperation, it was maybe you would exchange bananas and peanuts. And many of us, we joke about that. When we talk about South-South cooperation, it was mostly in speeches. But then as the South developed, there has been real South-South cooperation. Malaysia, you know, for instance, has been one of the leading actors in pushing for South-South cooperation with concrete examples. Today you have South Africa, but to give you an example, at the big outbreak of the conflict in Somalia, after years and years of different attempts at addressing that problem, the UN failed, the US failed, and it was the African Union particularly Ethiopia, Kenya, Uganda, that took their steps in deploying troops there. And at the time, people like myself were skeptical that they could address that challenge in Somalia. And they did head on. There have been some significant positive results. The country still in the midst of turmoil, but what they have achieved was unthinkable 30 years ago. In an area of the African continent that I'm dealing with in West Africa, particularly the case of Guinea-Bissau, the European Union, from the moral pedestal, imposed sanctions and withdraw any assistance. African Union, consistent with the existing policies today, which are to be uploaded, and that is zero tolerance on coup d'etats, suspended membership of Guinea-Bissau in African Union, to be uploaded. 30 years ago, that was unthinkable. They have developed outstanding human rights mechanisms in Africa. In Guinea-Bissau, who has shouldered the burden of preventing the conflict from getting worse, or poverty getting worse, is ECOWAS, in French or Portuguese, CDAO, the community of West African countries. And that is Nigeria, Cote d'Ivoire, Senegal, Ghana. They're the ones who shoulder the financial burden. They're the ones who deploy a small military contingent there. They deploy doctors. So 50 years ago, maybe we could only exchange peanuts and bananas. But today, there is far more, including in very effective regional cooperation. The question of Madagascar, for instance, the conflict there dragging for several years, it was SADCC, South African Development Corporation, that was handling it. Sometimes with extra-regional support. And last but not least, the example of Cuba, that was, Cuba should be commended for what it has done in health diplomacy. When my country began our independence in 2002, we hardly had any doctors. We were invited to send few students to Cuba to study medicine. A few years later, only for like 5 years, we had 700 Timorese medical students in Cuba, all paid by Cuba. They set up a medical school in my country, 300 students. In another 2-3 years, all of them have completed their studies. We will have the highest per capita doctor per population anywhere in Asia. And that is thanks to Cuba, a poor developing country, victim of US embargo and sanctions. So South-South, third world solidarity can happen, and it has happened, admirable. Also, in fairness to the partner countries, I might have sounded cynical, critical, but also the rich countries over the years have adapted. There have been more dialogue between recipient country and this donor country. It's not that, a rich country will come to my country, whatever, impose, no, this is what we want to do. No, they say, this is what we can do. We prefer, like in the case of Germany and my country, maritime transportation. So Germany supporting that, tremendous benefit for Timor-Leste. And now that Timor-Leste has a bit more money, we are doing a second phase of the program, co-finance, Timor-Leste and Germany, financing maritime transportation infrastructure in Timor-Leste. In other countries, is the same. It's no longer the West imposing on the recipient countries. So it has also improved, in fairness to, because after so many meetings, the Accra meeting, Paris Declaration, Busan Declaration, and many meetings in the UN, of course, World Bank, everybody adjusted. But much more has to be done in terms of a real allocation of the money to where it's most needed, and that is rural development, infrastructure, human resources development of our respective countries.
Well, thank you very much, Mr. President. I'm afraid that's all we're time's at an end. The barbarians are at the gate, so we got to get out of here. But you've seen a peek at all these new faces, new aspects of global health, and what so what we're thinking about for the future. So thank you all very much. Thank you for our panelists.